Hello, my name is Felix Feng. I'm a professor of radiation oncology, urology, and medicine, and also vice chair for the Department of Radiation Oncology at the University of California at San Francisco. And today it's my pleasure to talk to you about risk stratification for prostate cancer and the emerging role of genomic biomarkers in that context. Here are my disclosures. And I consult for a number of prostate cancer therapeutics and biomarker companies. So today I am going to divide my talk into two sections. In the first section, I'm going to talk about the current approaches for risk stratification for patients with localized prostate cancer. And in the second part, I'm going to talk about recent advances in risk stratification using genomic biomarkers. And so let's begin by discussing trends in prostate cancer over time. And so here's a plot of the incidence of various cancers in the United States over the last few decades. And on the top here, you can see that prostate cancer is the #1 diagnosed solid cancer in men in the United States over this time period. And it's kind of interesting because you can see that the incidence of prostate cancer apparently went up in the early 1990s, but that's also when PSA screening became more widely used. And more recently, the incidence of prostate cancer is decreasing, probably because, for better or worse, PSA screening is becoming less used, and that's actually an area of controversy that I won't touch upon today. But next to this, on the same scale, I want to put down the data for who unfortunately dies of cancer. And what you can see here is that shown in brown again is prostate cancer. And there's a couple big points to look at here. Number one, while a large number of patients are diagnosed with prostate cancer every year, as you can see on the left, a relatively small proportion of prostate cancer patients actually die of their disease. And so the vast majority of patients with prostate cancer live either with prostate cancer or they're cured of prostate cancer. The other point to bring up, though, is that the number of patients dying of prostate cancer every year is going down, and that's great. And I think that's due to better therapies, better diagnosis, and so forth. But overall, I think the take-home point is, well, we have some prostate cancers that can be lethal, but the majority of them are not. And so how do we distinguish the prostate cancers that are really bad from the prostate cancers that are not so bad? And what I think we should point out here is that prostate cancers can behave quite differently. And so this is kind of a depiction of the way I look at different kinds of prostate cancers. So some prostate cancers are like snails. They grow really, really, really slowly, and they may actually never be detected in the course of a man's life. Some are like turtles. They walk around, but you can see them over time. Some are like rabbits, where they hop relatively quickly, and some are like birds that unfortunately fly and progress relatively quickly. And when I see a patient with prostate cancer, it's important to perform appropriate risk stratification so I can tell the snails and the turtles from the rabbits and the birds. And so ultimately, I think accurate risk stratification is one of the most important components of the patient's care. And the goal is to inform both physician and patient decisions about optimal initial treatment approach and timing. So appropriate risk stratification helps us decide which patients should be on active surveillance. And while I'm not going to touch upon that today, Peter Carroll is going to talk about that subsequently. Appropriate risk stratification tells us who can proceed with early local therapy with, let's say, either surgery or radiation alone, or who needs multimodality therapy with more than one treatment because of the aggressiveness of the disease. And down the road, risk stratification can also point to who's going to have a higher risk of needing hormone therapy in the future. And so the D'Amico risk groups were one of the first approaches to risk stratification for patients. And this was based on 3 components. the PSA level, the Gleason grade, and the tumor stage. And so patients with low risk prostate cancer were defined as patients who had a PSA level of less than or equal to 10, Gleason grade 1, which was previously Gleason score 6, and also stage T1 to T2A disease. Patients with intermediate risk prostate cancer were those with PSA 10 to 20, Gleason grade 2 to 3. Previously, this was Gleason score 7, or stage T2B disease. And you only needed to have one of these characteristics to fall in the intermediate risk category. And patients with high risk prostate cancer were those who had any one of the following features: PSA greater than 20, Gleason grade greater than or equal to 4, which was Gleason score 8 to 10 back in the day, and stage T2C or greater. But it turns out that while the D'Amico risk groups were a better advance than what had previously been done, they themselves, could use a lot of improvement. And so more recently, the National Comprehensive Cancer Network, which puts out guidelines for physician treatment of patients for prostate cancer and other cancers, actually revised our original risk groups. And now there are 6 categories ranging from very low all the way to very high risk. And again, this is mostly based on PSA, Gleason score, T stage, but also takes into account in certain categories the number of positive cores, the percent positivity of any core, and PSA kinetics of sorts. But it turns out that for certain endpoints, like who is going to have metastatic disease and who is not, the NCCN risk groups are not ideal. And so here's a graph where on the y-axis, you can see what we call the cumulative incidence of metastasis, meaning which patients will develop metastatic disease over time. And the x-axis represents the time since diagnosis, or in this case, the time since radical prostatectomy or surgery. And basically for these plots, the higher they rise, the more patients are getting metastatic disease over time. And so what you can see is that patients with low and favorable intermediate risk disease have a low chance of metastasis over time. Those in this particular study with unfavorable intermediate risk or high or very high risk had a higher chance. But ideally, what we want to see is we want to see a bigger dynamic range, meaning that we don't want the blue line to be on top of the yellow line and the gray line to be on top of the red line. We want them to actually be separate from each other, so that we can have a kind of more detailed approach, more accurate approach of telling patients what their prognosis is going to be. And part of the reason why the NCCN criteria may not be as ideal nowadays is that the criteria that are used to define the groups kind of are considered inconsistently. So, for example, very low risk prostate cancer, let's say it looks at the number of cores positive, but the majority of the other risk groups don't incorporate that. And so, I think we can do better. And actually, a number of years ago, Matt Kupperberg and Peter Carroll ran one of the first studies looking at the CAPRA score. And this is the CAPRA stands for the Cancer of the Prostate Risk Assessment. And what they did was they developed a classifier where they broke down PSA into smaller divisions, Gleason score, tumor stage, which is a physical exam, the percent positive biopsies, and also included age. And ultimately, this could be grouped into 3 groups, but was intended to validate and perform as a scale from 0 to 10. And so it gives you what we call a better dynamic range, better risk stratification. And so this is what the CAPRA score gets you in terms of looking at outcomes as a function of time. And so on the y-axis here is what we call the proportion of event-free survival. And so this is the amount of time that goes by where somebody does not die of prostate cancer. And on the x-axis is the time after diagnosis. And what you can tell here is that the likelihood of cancer mortality ranges from 0 to greater than 65% at 15 years down the road. And that, again, you can tell that patients with a CAPRA score of 0 is on the top, CAPRA score 1 is right under that, CAPRA score of 10 is on the bottom. And so, this gives you what we call a better dynamic range. And so instead of the previous plot that I showed you with the NCCN groups where the low favorable intermediate risk were clustered together and the unfavorable intermediate risk and high were clustered together, here you can see that there's just a much nicer spread. And so, for a patient, you can actually have a more accurate risk stratification. And each 2-point increase in CAPRA indicates roughly a doubling in risk. And this is kind of the tools we use nowadays when patients ask about their prognosis. We can actually give them kind of more accurate information. So one question we can ask is, what has been the most significant recent advance in risk stratification for patients with prostate cancer? And my answer to that is genomic biomarkers. And so this is a snapshot from the NCCN guidelines. These are national guidelines for physicians on how to treat prostate cancer. And this is the 2021 guidelines. It's still in draft form. But I want to point out that there are now 4 different genomic biomarkers which are now reimbursed by Medicare. And these are Decipher, Prolaris, Oncotype, and ProMark. And of all of these, Decipher and Prolaris have the broadest coverage, meaning they're now insurance reimbursed for all patients who have non-metastatic or who have localized prostate cancer. And I don't want to go into all the detail today, but I think it's important to point out that all of these different genomic biomarkers have been demonstrated to improve risk stratification when added to clinical features. And actually, there are 3 that are more commonly used. And these are the Oncotype DX tests, which is made by a company called Genomic Health. And there's the Prolaris test made by a company called Myriad Genetics. And there's Decipher made by Decipher Biosciences. And for those of you who are interested, I can discuss all the nuances between these different tests. But today I'm going to provide a kind of a bigger overview. And in general, I tend to prefer Decipher. And the reason why I tend to prefer Decipher is that it's the most broadly validated. So there's been the most number of independent studies looking at what Decipher adds to clinical risk stratification for patients. The other point is that Oncotype measures the expression or the level of 17 different genes. Prolaris measures the level of 46 different genes. The Decipher platform actually, every time it's run, measures the level of 46,000 genes. It outputs a score actually that's only based on 22 genes, but you can get something called the Decipher grid, which provides the data on all 46,000 genes kind of summarized based on signatures and so forth. And so I'm a big believer that more information is good. And also Decipher was the first prostate cancer genomics test to be approved broadly for any patient with non-metastatic disease. And so I've gotten in the practice of ordering it because I didn't need to make sure that this patient had low risk prostate cancer. I could only order this test. For intermediate risk, I could order another test. Decipher, you can order across the board. And so it turns out that Decipher is prognostic, meaning it adds to risk stratification with clinical variables across the spectrum of prostate cancer. And so here, this is kind of a plot summarizing many of the studies that have reported out associations between Decipher and various clinical parameters like adverse pathology at the time of surgery. BF stands for biochemical failure or PSA recurrence. MET stands for the chance of having metastatic disease down the road. And PCSM stands for prostate cancer specific mortality, meaning who's going to live or die of from prostate cancer, unfortunately. And this red line is basically the line where if these dots and their surrounding lines cross this red line, it means that Decipher was not adding any important information. But here, what you can see is across these broad range of studies, all the dots, all the blue and gray and black dots and lines are to the right of the red line. And what that means is that in each of these studies, Decipher is providing important information on the aggressiveness of prostate cancer. And so I want to go back to this plot where I showed you earlier of patients who had surgery, and this is the incidence of metastasis over time. And remember, one of my critiques is that when using conventional NCCN risk groups, there's only really basically two categories. The blue and the yellow are together, and the red and the gray are together. A couple of years ago, we incorporated Decipher into these NCCN risk groups, and now you can see that there's a much nicer spread. And what that means is that my patients, they don't want to necessarily know if their disease is just good or bad. They want to know whether it's, I guess no disease is ever good, but they want to, the some don't ever really need to be treated, and so they want to know whether their disease is very good, good, okay, good, just okay. Okay, maybe I should worry a little bit, or maybe I should worry a little bit more. And so, putting Decipher into those clinical risk groups, I think it really gets us there. Now, another question we can ask is, how can better risk stratification improve patient care? And the way I think about it is that patients with less aggressive disease should receive less aggressive treatments and be spared the side effects of certain treatments. On the other hand, patients with more aggressive disease should receive more intensive treatment to maximize their chances at cure. And overall, the way I view it is that better risk stratification equals better personalization of care. And so here's an example of how we can use Decipher to potentially guide treatment for patients. And so this is a study that looked at the use of Decipher in patients with intermediate risk prostate cancer defined by kind of clinical parameters, and they were all treated with radiation alone. And this was from the University of Toronto, led by a colleague of mine, Ali Berlin there. And these are Kaplan-Meier plots, and you might see them through the rest of this conference. But the Kaplan-Meier plots, what they indicate is a certain event happening over time. And so in this case, the y-axis represents the number of patients who have not had a metastasis over time. And so for each of these lines, if patients do perfectly well and they never have a metastasis, the line stays completely at the top, like this blue line does. But if patients end up having a metastatic event, every time there's a patient with a metastasis, the line starts dropping down towards the bottom. If every patient has a metastasis, the line would be all the way down at the bottom. And so again, this was a relatively favorable group of patients, intermediate risk disease, but they ran Decipher on all of them. And patients with low Decipher score are shown in blue, those with intermediate are shown in the yellow, and those with high Decipher score are shown in the red. And I think the point to bring up here is that patients with low clinical genomic risk, meaning low Decipher scores, had no metastatic events when treated with radiation alone. And this was important for us clinically because for patients with intermediate risk prostate cancer, we often consider whether we should treat them with radiation and hormone therapy or radiation alone. And here, what this study suggests is that maybe with patients with low Decipher score, you can feel somewhat comfortable, perhaps, using radiation alone. But this was a smaller study, and so we wanted to be able to confirm this on a larger patient set. And so in one of my other roles, I chair a large international clinical trials group called NRG Oncology. I chair the Genital Urinary Cancer Committee for this group, and this means I oversee a large number of international, national clinical trials for patients with prostate cancer. And so this was one of our studies. It's called the Guidance Trial, and the number is also abbreviated GU10. And it's for patients with previously untreated, unfavorable intermediate risk prostate cancer by clinical parameters. It's a large study, 2,430 patients. And where this study actually has not started enrolling, but when it does enroll, which we hope it will open, that we hope this trial will open in the next year or so, we're going to have all patients undergo Decipher testing. And those patients with low Decipher score are going to be randomized to one of two arms. Arm 2 in this case is radiation and short-term androgen deprivation therapy, and that represents the standard of care for patients with unfavorable intermediate risk prostate cancer by just clinical parameters. But because we know that low Decipher score might indicate patients who might do quite well with just radiation alone, what we're doing is we're randomizing these patients from arm 2, which is the standard of care, to arm 1 as well. So half of them will be in arm 1, half of them will be in arm 2, and in arm 1, they get less aggressive treatment. Now, for patients with intermediate to high Decipher scores, we're actually also randomizing them again to the standard of care, which is radiation and short-term androgen deprivation, as well as a more aggressive treatment arm that involves adding the next generation anti-androgen darolutamide to radiation and short-term androgen deprivation. And so here you can see that genomic testing is being incorporated into, big phase 3 trials nationally, and I think in a couple of years from now will become widespread in use in probably the standard of care. Now, I showed you data on patients with intermediate risk prostate cancer. It turns out that if you look at patients with high risk prostate cancer by standard clinical features, Decipher can identify a subset of these patients at very low risk for metastatic progression when treated with standard of care, which in this case is radiation and long-term androgen deprivation therapy. And so here you can see a plot where the y-axis is how many patients got metastasis over time. And if you take the low Decipher group shown in blue here, almost none of them ended up with metastatic progression compared to patients with intermediate to high Decipher score. And all of these patients, again, had high risk disease. So similar to the previous study in intermediate risk prostate cancer, we are starting the PREDICT RT study in patients with high risk prostate cancer. This study is actually open and accruing nationally. It's going to accrue 2,478 patients, and this will be patients with previously untreated high-risk prostate cancer by clinical parameters. And as again, similar schema from what I showed you previously, patients with low or intermediate Decipher scores get randomized to the standard of care, and which for these patients is radiation and long-term androgen deprivation therapy. And if they have a low intermediate Decipher score, 50% of them will be randomized to a less aggressive treatment course, half the duration of hormone therapy as in the standard of care arm. If they have a high Decipher score, these patients will be randomized where half of them will get a more aggressive treatment approach where the next generation androgen-directed therapies, abiraterone and apalutamide, are added to the standard of care. And so again, this is how we're using genomic biomarkers to really guide patient care through randomized clinical trials. So the data I've shown you so far has been in the context of newly diagnosed prostate cancer for patients who have not had any treatment. It turns out that Decipher can also improve risk stratification in patients who have already had surgery. And so here you can see the incidence of metastasis over time. And what that means is that the higher the curve goes, the more patients in that group are developing metastasis. And so what you can see is that in patients who have, this was a large cohort study that Dan Spratt, who's a previous mentee of mine, and I did a number of years ago, where we took patients who had surgery, ran Decipher scores on them, and saw that patients with low Decipher score did better than patients with high Decipher score. And on this plot here, again, this is similar to what I showed earlier. This is a forest plot where the red line is the line which if these blue dots with their surrounding black lines cross the red line, then Decipher isn't providing any value. But you can see that the yellow line is set off from the red line. Yellow line indicates kind of the average performance of Decipher across all these subgroups of patients with prostate cancer based on race and PSA and Gleason score and surgical margin status. And across the board, basically, Decipher is adding value in all patient subsets, in patients who've had surgery, in terms of risk stratification. And there actually are important implications here. So it turns out that after surgery, Decipher scores may identify which patients benefit from adjuvant radiation, which is radiation given when the PSA is undetectable, versus salvage radiation, which is radiation given when the patient has unfortunately had a PSA that's come back. And so this basically relates to the timing of radiation after surgery. And what this is showing is that in patients with low Decipher score, there's no difference in outcome between those who got adjuvant versus salvage radiation. And what this suggests is that, patients who have aggressive disease found at the time of surgery, if they still have low Decipher scores, probably the standard of care would be just to wait, not do anything. And if their PSA happens to come back, then you radiate at that point in time. Now, conversely, patients with high Decipher scores, they appear to benefit from adjuvant radiation, meaning earlier radiation compared to salvage radiation, which means radiation once the PSA is detectable again. And so, potentially for patients with higher Decipher scores, we should be more proactive with giving radiation after surgery. Now, another question we can ask is, can Decipher be used to identify which patients should receive androgen deprivation therapy with salvage radiation after surgery? And for this, I'm going to rely on the RTOG 9601 trial, which we published in the New England Journal of Medicine a few years ago. And this study was a large phase 3 trial for patients who had recurrent PSA recurrences after surgery for prostate cancer, and they were randomized to salvage radiation, meaning radiation when the PSA was detectable, and you can see the PSA range here, which was either given with 2 years of the anti-androgen therapy bicalutamide or 2 years of placebo. And what this showed was that 2 years of bicalutamide improved the overall survival of patients by about 5% after 12 years. And that 5% may not seem like a lot, but whenever we get a survival improvement in the context of prostate cancer treatment, that survival improvement is quite meaningful because you can imagine a standard population of patients with prostate cancer is 65 to 70, and those patients unfortunately may be dying of other things outside of prostate cancer. So there's what we call competing risks, of mortality. And so any improvement that you can see with an intervention causing improved survival in these kind of patients with prostate cancer, we tend to pay attention to. But anyway, the flip side is that, well, again, 5% benefit is not that much. Can we improve the risk stratification so we have a better sense of who benefits from the hormone therapy and who doesn't? And so here again, I think we can show the value of genomic profiling with Decipher. And so what these plots represent is the absolute percentage chance of having a 12-year distant metastasis. This is on the left. The 12-year rates of prostate cancer-specific mortality, that's in the middle, and that means the chance of dying from prostate cancer 12 years after treatment. And then 12-year overall survival, meaning who's alive or not alive at 12 years after treatment. And what we've done is we've broken down the patients from this trial based on their Decipher risk, meaning we went back, got the samples, and profiled the samples from this trial with Decipher. And what I want to point out is that patients with the low Decipher score, shown in blue, they seem to have a much smaller benefit from hormone therapy than patients with intermediate and high Decipher score, shown in red. And so what we've done here is we looked at, for example, on the left, the 12-year metastatic rate in patients who had low Decipher score, who were treated with radiation alone versus radiation plus hormone therapy. We looked at that difference, and that difference is what's plotted here. And so hormone therapy is only improved the 12-year metastatic rate by about 5% in patients with low Decipher score, but it was about 15.7% in patients with intermediate to high Decipher score. And when you look at these other endpoints, you can see that really the benefit of adding hormone therapy in patients with low Decipher score is much less than the benefit of adding hormone therapy in patients with intermediate to high Decipher score. Now, the previous plots I showed you is in men who had a range of PSA from 0.2 to 4 after surgery. Now what I've done is I've restricted the same analysis to patients who had what we call early salvage radiation, meaning radiation when the PSA levels were low, below 0.7 in this context. And now these are the same plots, and you can see, again, there's almost no benefit to hormone therapy in terms of distant metastasis and prostate cancer-specific mortality in patients with low Decipher score. There continues to be a benefit in patients with intermediate to high Decipher score, but what's particularly intriguing and a little bit, is something that we really probably should be paying attention to, is that the overall survival of patients who got hormone therapy added to radiation was actually worse than the patients who just got radiation alone for patients with low Decipher score and low PSAs. And this study, unfortunately, wasn't large enough to show statistical significance. And so I don't really know whether we can say hormone therapy is hurting patients. But I think what we can say is that, hormone therapy has potentially some untoward side effects, on heart disease, and so forth. And so in patients with low Decipher score, low PSAs after surgery, I think they can be treated with radiation alone, not and may be spared hormone therapy. And so in conclusion, accurate risk stratification is important for patient-physician decision-making. Genomic biomarkers improve risk stratification and are now reimbursed by insurance carriers. And these genomic biomarkers can help identify who needs more aggressive versus less intensive therapy. I'd like to thank all my collaborators who contributed to the study and also acknowledge my wonderful laboratory team, which is shown here, who helps out with some of the research that I showed today. Thank you for your time and your attention.
Thanks, Felix, for that very comprehensive talk. What I'd like to do, there's been a number of questions, but I'd like to frame a couple of them for you. So you've talked about a number. Actually, let me take a big step back and ask you to differentiate for us. What's the difference between one of these classifiers and what you hear about, mutations in prostate cancer, like a BRCA mutation or things like that? Are we talking about the same thing here, or is it different?
Yeah, it's a great question, Eric. So the classifiers I talked about today, including Decipher, measure the levels of something called RNA in cancer samples. And mutations are in the DNA of cancer samples, and they can also be in the DNA of normal cells as well. And so the difference here is there's RNA-based markers and DNA-based markers. I won't go into the differences between RNA and DNA, but they're different components of cells. Now, with regards to particular mutations, I think there was a question about BRCA mutations and so forth. So BRCA mutations are interesting because a patient who has a BRCA mutation may actually have that mutation in all the cells of their body. And then one of those cells forms prostate cancer when it picks up usually a second mutation in that same BRCA gene. So there are different types of genetic or genomic testing that patients can undergo. What I talked about today is kind of testing of the cancer sample itself. Okay. But for some patients, if you're worried about BRCA and so forth, if there's a strong family history of prostate cancer, and there's people diagnosed with prostate cancer at young ages in that family, you can take a normal blood sample and look for a BRCA mutation to see whether that particular patient is at higher risk of developing cancer. My talk today was about the risk of cancer progressing once that cancer has been diagnosed, but you can also use genetic tests to try to predict the risk of even developing the cancer to begin with.
Good, thank you. So let me just ask, this will also get at a couple of other questions. You spent a lot of time talking about Decipher. And there's been some questions about comparing and contrasting one test to another. I'm not going to ask you to do that as much as, is there reason, if a patient who's on the line, who's watching this conference, that their doctor has obtained an Oncotype DX test, that they should ask for a Decipher? Are there reasons to switch from one to another? Is there reason to get more than one? How should patients approach this?
Yeah, Eric, so I think it's a great question. And I think the answer is that it depends. But in general, I think one easy answer is that, for example, Oncotype is not approved in all cases of localized prostate cancer. It's mostly approved for lower risk prostate cancer, whereas Decipher, Polaris are approved for across the board, including for patients with more aggressive prostate cancer. For the studies that I showed earlier, like if you're thinking about, let's say, whether you should get radiation alone or radiation plus hormone therapy, I think Decipher is probably the most validated in that setting. And so in that context, I think there is a difference between Decipher and Oncotype, not because Oncotype doesn't necessarily work, but because it hasn't been tested in that specific clinical setting.
Okay. And then let me just clarify one more thing. Is there any role for any of these tests to help patients with, which we'll be talking about tomorrow, say in the setting of metastatic disease?
So these tests are largely to identify who's going to have aggressive disease or who isn't. By the time you have metastatic disease, I think your disease has declared itself. And so these particular tests are probably less useful. Now, there are plenty of other genetic tests. At that point in time, you want to look at mutations and you want to look for, things associated with small cell prostate cancer and, specific mutations that actually may predict response to specific drug treatments, but not necessarily the ones I talked about today.
Okay. Just that's good. It's a good distinction that these tests really are useful for defining risk in men primarily with localized disease. And tomorrow, when we talk about advanced disease, we will be talking about the genetics of those patients. Great. Thank you very much, Dr. Feng.